Hello everyone. The next developmental disturbances of tongue I'll discuss today, that is geographic tongue or benign migratory glossitis. In this video, I'll discuss about the introduction part, then etiological factors, clinical features, histopathological features and treatment plan for geographic tongue. Coming to introduction, geographic tongue is also known as benign migratory glossitis, erythema migrans, wandering rash of the tongue, erythema areata migrans, or stomatitis areata migrans. These are some other names of geographic tongue. Geographic tongue is a common benign condition that primarily affects the tongue. It is often detected on routine examination of the oral mucosa. This kind of lesion occurs in 1 to 3% of the population, and females are affected more frequently as compared to male in a ratio of 2:1. Patients occasionally consult a healthcare professional if they notice any unusual appearance of their tongue, or if the lingual mucosa becomes sensitive to hot or spicy food. Then etiological factor. Even though geographic tongue or erythema migrans has been documented for many years, the etiopathogenesis is still unknown. Some investigators have suggested that geographic tongue occurs in increased frequency in atopic individuals, thus raising the possibility that it represents a type of hypersensitivity reaction to an environmental factors. Another etiological factor can be after oral contraceptive pill or oral contraceptive therapy. They are suggesting that it may be due to hormonal factors. So these are some etiological factors for geographic tongue or erythema migrans. Then clinical features. The characteristic lesions of geographic tongue are seen on the anterior two-thirds of the dorsal surface of the tongue mucosa. In the diagram or the picture you see, there is a atrophic area or more red color area which is surrounded by a white or yellow color borders. So they appear as multiple well demarcated zones of erythema, that is more red color, and concentrated at the tip of the tongue and lateral border of the tongue. First picture showing the geographic areas present on the dorsal surface of the tongue. In the second picture you can see there are atrophic areas on the lateral border of the tongue. This erythema is due to atrophy of the filiform papilla, and these atrophic areas are typically surrounded by a slightly elevated yellowish white serpentine or scallop border. Patient usually describe the lesions as appearing quickly in one area, healing within a few days or few weeks, then developing in a very different area. The lesion begins as a small white patch, then develops a central erythematous atrophic zone, and it enlarges centrifugally. Often patients with fissured tongue are affected with erythema migrans. The lesions of geographic tongue, they are usually asymptomatic. The patient doesn't show any symptoms. There is no pain, no burning sensation. But sometimes there is a burning sensation or sensitivity to hot or spicy foods, that these burning sensations may be noted when the lesions are active. In the picture, in the diagram, you see the palatal lesions that shows a erythematous area. In this is the palate, posterior part of the hard palate, and some parts of soft palate are involved, and this is well demarcated erythematous area which is surrounded by a white border, which are similar lesion those seen in the tongue. Lesions develop on the buccal mucosa or on the labial mucosa and less frequently on the soft palate. In these areas, it can be identified by a yellowish white serpentine or scalloped border that surrounds an erythematous zone. Because of this appearance, it may be confused with candidiasis or erythroplakia. In the picture, you see there is serpentine borders that are present on the lower labial mucosa. These are all erythematous area which are surrounded by a white borders. If a biopsy specimen of the peripheral region of erythema migrans is examined, a characteristic histopathologic pattern is observed. So these are the histopathological features which are seen under the microscope, like your hyperparakeratosis, spongiosis, acanthosis, and elongation of the epithelial retiges. Hyperparakeratosis, there is a increase, you can see there is an increase in the keratin layer which is present above the surface epithelium. A thickened layer of keratin is infiltrated with neutrophils, and these inflammatory cells often produce small microabscess called Monroe's abscess in the keratin and spinous layers. Retiges are typically elongated and thin, with only a thin layer of epithelium overlying the connective tissue papillae. These are the retiges which are elongated. These are elongated retiges, and there is an abnormal thickening of the spinous layer, that is your acanthosis, and there is increase in the parakeratin layer in the surface epithelium, that is your hyperparakeratosis. In the last picture you will see there is an elongated retiges. When the retiges are not elongated, it should consider Reiter syndrome as a diagnostic possibility. The intense neutrophilic infiltrate, which is inflammatory cells, may be responsible for the destruction of the superficial portion of the epithelium, thus producing an atrophic red mucosa as the lesion progresses. Because these histopathologic features are reminiscent of psoriasis, this is called psoriasiform mucositis. In this histopathologic picture, this is the medium power photomicrograph. It shows collections of neutrophils in the superficial spinous layer of epithelium. A Brazilian study determined that both psoriasis and patients with benign migratory glossitis were likely to have same human leukocyte antigen group, namely HLA-CW6. Both psoriasis patient and patient with geographic tongue, they share a similar human leukocytic antigen. Silver or PAS staining, that is per-iodic acid sheaf stain, they will demonstrate candidial hyphae or spores in the superficial layers of the epithelium. If there is no liquefactive degeneration of basal cells, those are seen in lichenoid lesions, and there is no ulceration except Reiter's syndrome, that are histopathological pictures of your benign migratory glossitis. Next is treatment plan for benign migratory glossitis. So there is no treatment is usually necessary for erythema migrans or benign migratory glossitis. Symptomatic lesions like patients may complain of tenderness or a burning sensation that is so severe that it may disrupt their lifestyle. In that symptomatic lesions, it can be treated with topical prednisolone. This topical prednisolone may provide relief when it applied as topically as a thin film several times a day. Next, if there is a secondary candidiasis, then a topical or systemic antifungal medication is prescribed. Occasionally, symptomatic cases respond to topical tetracycline or systemic broad-spectrum antibiotics. One study recently suggested that zinc supplementation may be effective for symptomatic erythema migrans. So these are all about basic description of benign migratory glossitis. In that I have discussed the introduction part, etiological factors, clinical features, histopathological features and treatment plan for geographic tongue or benign migratory glossitis. Hope you like this video. Thank you so much.